Good evening, ladies and gentlemen, dear Achilles tendon friends. My name is Carsten Knobloch from Germany, and I'm highly delighted to talk about my most beloved tendon, the Achilles tendon. So I'll start with my conflicts of interest. So in my practice in Hanover, I'm starting usually with a risk factor analysis. I will give you some more arguments scientific-wise later on this, followed by multiparametric ultrasound, leading to an individualized, tailored treatment for your given patient. In risk factor analysis, I'm looking on load, on medication, on blood levels of cholesterol and urea, and even on genetics. You are aware that overloading is a big issue, and it's known for running athletes that you can increase your mileage per week by mainly 10%. If you increase faster, say 15, 20, 30%, you will end up most likely with some overuse injuries, such as the Achilles tendon. We are aware that there are some medications which can be detrimental for your Achilles tendon health. There is cortisone, quinolone antibiotics, aromatase inhibitors, and statins for lowering cholesterol, especially in combination of, say, quinolone and cortisone in medication in patients aged 60 or older. You can see that the adjusted rate difference is nearly 7 out of 10,000. So this is a patient group of special risk for Achilles tendon problems. It is known that ibuprofen and other non-steroidal anti-rheumatic drugs can have detrimental effects on the turnover of the tendon and therefore limit the tenocyte division. Recent reports highlight that maybe even for bisphosphonates, there might be dose-wise problems with higher frequencies of tendinopathies, especially alendronate is showing the highest association of an odds ratio of 16 in contrast to other osteoporosis medications. Jill Cook and colleagues showed beautifully in a meta-analysis that higher cholesterol is adjacent to higher Achilles tendon risk. This is true for lower HDL and higher LDL cholesterol levels as well. So the worse your cholesterol levels, the worse potentially your Achilles tendon. Bernie Segesser, the founder of the Rennbahn Clinic in Switzerland, always told me that he applied allopurinol to influence the urea levels, especially in Achilles tendon patient. And he is still true because science is supporting the correlation. So in a way, metabolic risk factors, cardiovascular-wise, may worsen tendon health, as shown by Karin Silbernagel just this year in the Journal of Orthopedic Research. A novel observation is, I would say the jury is still out there, that especially in the NFL, the risk for or the frequency of Achilles tendon ruptures is especially during and after COVID times significantly increasing. It is unclear what the mechanism is, but it is an observation. As you can see, quarterback Aaron Rodgers, when traded on his first game in September for the Jets, he suffered in this situation Achilles tendon rupture, and Kirk Cousins, at that point of time, the quarterback of the Minnesota Vikings, suffered the very same injury on November 1st in 2023. Genetic profiling is an option. Martin Schoenus from Pretoria, Southern Africa, has shown beautifully that on the long arm of chromosome 9, there might be mutations, and these can be commercially analyzed by kits like this one from United Kingdom, which I did on my own. And DNA Fit showed that my genetic injury predisposition is pretty high, as you can see, in contrast to other patients or athletes. And you can see my personal genotype in terms of the collagen 1AA and collagen 5A one locus with my genotype, which might have a detrimental effects on my personal Achilles tendon health as well. As far as imaging is concerned, we not only look on the intrinsic tenocyte part, but also on the vascular, on the nerval, and the immune system as an extrinsic compartment. Back in 2002, this is from the British Journal of Sports Medicine, and you see two images on the long axis, on the left hand, on the short axis, on the right hand of ultrasound, published by Amol Saxena, who will speak later this evening at 10 a.m., and Nick Mafuli, who will speak just after me, after the break, and showing you how 23 years ago ultrasound resolution was. And I'm very delighted and honored that Nick is just around the corner after my talk. So please tune in to see Nick's view on the Achilles tendon. It is clear that the anatomy based on modern ultrasound analysis is more complex than we thought. So you see, there might be variations both for the insertion of the soleus and for the gastrocnemius, as you can see in this analysis. And I'm happy that Ine Müller just yesterday provided me with her PhD awarded paper published in the British Journal, highlighting and emphasizing again the role of the triceps surae muscle tendon unit during rehabilitation. In ultrasound, we can now apply, and this is my machine, a Canon Aplio E800 in grayscale in insertional Achilles tendinopathy, as you can see in the left upper panel. Then you can apply power Doppler ultrasound. You can apply advanced dynamic flow, and now you can even apply superb microvascular imaging. So this is specialized and ultra high resolution Doppler modes to elicit and to create an idea of the vascular architecture of the neoinflammation. And this is shown on the long axis. You can see it on the short axis as well. So you can see the vessels entering more lateral, more medial from the carga fat pad into the tendon. And this helps you quite a lot when you try to do ultrasound-guided injection techniques, for example, which I will refer on later. You can now even measure and quantify vascularization. So the SMI allows to create the vascular index as a region of interest. So in this case, it is 10% vascular index, and this can be done before and after each treatment, what you do, and so you can see and follow the course of the of your patient. My tendon career started with this very little study using a microcirculatory tendon mapping system called Oxygen 2C, and we could show that at the point of pain in mid-portion Achilles tendinopathy, we had significantly higher laser Doppler flowmetry values than in the asymptomatic contralateral side, as you can see here. And this was published in the American Journal at that point of time in 2006. And Anja Hirschmüller has shown beautifully when she was still in Freiburg in southern Germany with Norbert Südkamp, that among marathon runners who want to run the Freiburg Marathon 1 year later, the presence of neovascularization in asymptomatic patients or in asymptomatic runners is a predictive factor for the development of Achilles tendinopathy. So the odds ratio over the 1 year of marathon training was 7 among these running athletes. And this is supported by paper, a very recent paper. I just received it yesterday by Daniel Kuschmann, showing that pre-screening with ultrasound in an athletic cohort at the beginning of the season can really help you quite a lot in identifying athletes at risk for patellar tendon, especially for the Achilles and for the plantar fascia, as you can see with the relative ratios. So very, very good and solid paper just published in the British Journal recently. As far as ultrasound is concerned, we can even apply elastography, and we differentiate strain elastography, which is only semi-quantitative and has, in my view, no scientific argument in this very moment, while shear wave elastography is quantifying stiffness, which is user independent. These machines cost much more because it's much more complex to build. And I show you the history of the short history of shear wave elastography, one paper by Karin Silbernagel and colleagues in 2015. This is 2017. You see even better resolution and the values displayed in kilopascal. And now with the modern shear wave elastography mechanisms, you can now assess in all these fields the elasticity or the stiffness, which is displayed as an average plus the standard deviation. And the smaller the standard deviation is, say less than 10%, for example, the more credible are your values. So this adds up much more information on your tendon health. So we do ultrasound grayscale diameter measurements. We do SMI, superb microvascular imaging, for the degree of vascularization, and shear wave elastography to measure the stiffness in a multi-parametric view. And Jill Cook and colleagues just recently shown an interesting outview that maybe even artificial intelligence might help in the future in providing a roadmap for ultrasound assessment in your Achilles tendons. So as far as treatment is concerned, the question is how to accelerate healing. And my idea is to best heal even faster. And on the last year's German foot meeting, DAF in Vienna, I had the pleasure to lead with Kyriakos Danielidis, who has spoken this afternoon already in this very event, the concept of the regenerative clockwork. The idea is that you combine different measures. So in tendons, you can combine radial and focused shockwave, low-level laser therapy, oscillating magnetic fields, plus different injection techniques, hyaluronic acids, PRP, polydocanol, maybe exosomes or collagen. And do not forget to optimize loading, to apply eccentric, most likely even proprioceptive work and kinesiotaping. And then this is the framework I'm now considering for precision and coordination, because in my view, it plays quite a role in what sequence the different tools are applied to the best of our patients. Load optimization, this is Karin Silbernagel, is very important, and I often or usually apply this pain monitoring model, meaning that patients are allowed to load their tendons to a visual analog scale level of 5 out of 10, usually with good results. Eccentric training in combination with concentric training with the appropriate dosage is important. Håkon Alfredsson from Romeo has shown beautifully that in the moment you have the lower position on the stair, the blood flow will somehow diminish. We could show nearly 19 years ago that if you do 2 or 3 months of daily painful eccentric training, the blood flow will be reduced by 50%. We interestingly found that females suffering from Achilles tendinopathy doing the very same dosage of eccentric training do not respond as good as males to this exercise regimen because microcirculatory changes are evident amongst gender as well. And when I met Jill on a very cozy evening in Auckland on the ISMST Shockwave World Meeting, we came in a dinner talk to the idea that for mid-portion Achilles tendinopathy, the decline under 0 degree is important, and the concentric components, so eccentric and concentric, while on insertional, because you create in Kagas fat pad in kind of impingement, it is good that the eccentric should stay to the level and do not do the decline more negative. And the concentrics are much more important. So depending on the location of your Achilles tendinopathy, insertional or mid portion, one should modify stairs, yes or no, in our view. I'd even apply or combine it with, for example, vibration work on a power plate, where you really can load something to a much different degree. And it is known, just recently published, that patients with painful Achilles tendinopathy usually try with some compensation strategies when doing these exercises. So it's very, very important to closely or supervise or even use mirrors or something to have appropriate exercise regimen. And the brain may play a role in this regard as well. It's known already 10 years that kinesiophobia may be linked with less good outcomes in Achilles tendinopathy. And just recent reports show that there is a link in between anxiety, depression, fear of movement, and fear of Achilles tendon rupture in a number of patients. So the brain plays a very integral part in this view. And as this is an innovations talk, I will show you the HALO system. And the HALO system is a measure to stimulate the motor cortex, like deep brain stimulation. And the mechanism is called neuropriming. And this technique helps the brain to enter a state of heightened plasticity. And this is termed hyperplasticity. And during this period, which is 30 minutes, for example, the brain adapts to the training much, much more effectively. You might combine eccentric training, maybe on the power plate, even with neuropriming. So you have deep brain stimulation during your exercise. And a future additional way is that maybe even shockwave play a role on the brain. We have a CE certified machine, MRI navigated electromagnetic shockwave, where we do focus shockwave on distinct areas of the brain. And there's a recent report from Vienna showing in healthy volunteers stimulated to a distinct motor region in the brain by focused shockwave, that behavioral tasks, so motor learning, can be substantially improved with the help of focused shockwave in these tiny areas of the brain. So this is what I foresee for the future. There is even reports besides the eccentric for proprioception, and an ankle or a reduced ankle proprioception is just recently shown linked with Achilles tendinopathy. And this has been shown in clinical 10 years ago already, or 15 years ago, when we analyzed the proprioceptive training for female squad of Bayern Munich, and could show a significant reduction over 3 seasons for Achilles tendinopathy when doing proprioceptive work. So besides the eccentrics and concentrics, it is worth to consider proprioceptive training as well. Medical flossing, or in the US, voodoo flossing, might be an option as well, where you can combine your eccentrics and concentrics with a tourniquet, which apply as well. And this might help quite tremendously in reducing the blood flow. And you see, this is my own mid-portion Achilles tendinopathy in 2016, when I was still marathon running. So I had some 9 to 10 millimeters AP diameter. You see my neovessels. And immediately after 3 minutes of flossing, as you can see here, 4 minutes later, this neovascularization was significantly reduced. So a similar effect, which I usually see with polydocanol injection, but this is needle-free, only by tourniquet. So there is no hyperemia after. And this leads the way to even combining compression and cryotherapy. And when I was young, as you see, we did study on the AirCast CryoTough, where you have compression and cryotherapy, and measured microcirculation of the Achilles tendon. And you see the main effects within the first 10 minutes of cooling, and then there was less extent of reduction of the microcirculatory blood flow. We then had the idea to do, like in cardiac surgery, ischemia and reperfusion, 3 sets of 10 minutes cryocuff, showing a superior change in Achilles tendon microcirculation. And this holds true for the cryocarf. And we did the very same with the cold blue, different cooling device, as you can see, published in the British Journal as well. So this intermittent cooling and compression therapy appears to be pretty good. And this led to the idea of the price system. And in nowadays, it's not only price, but also peace and love. Very, very easy to memorize: protection, elevation, avoid, please, anti-inflammatory drugs. I showed you before, ibuprofen, compression and education, plus load optimization, optimism, vascularization, and exercise. Please apply peace and love. There is an interesting study published, I think, in 2002 by Paoloni and colleagues from Australia, showing that topical NO could significantly reduce pain after 3 and 6 months, as you can see here. They did a long-term follow-up up to 42 months, still showing that the GTN topically applied was pretty successful. And we did microcirculatory assessment, showing that there are no changes in the, let's say, capillary blood flow, but we see a facilitated venous outflow post-capillary. So there seems to be some changes of the GTN, which are beneficial for collagen turnover. So this might be an option. And recent data shown for curcumin in osteoarthritis, showing a very strong interaction with matrix metalloproteinases. And this is very important in tendinopathies, as you might know as well. So I foresee that curcumin and other phyto medications might play a, let's say, evolving role in the treatment of tendinopathies. Energy-based therapies involve shock waves, laser, magnetic fields, and vibration. And in shock waves, we differentiate radial pressure waves, which act like an air gun, and focus shock wave with different generators. And it's very important to stress out in this moment, the treatment parameters really matter. So you might have an appropriate machine with wrong parameters, you will end up with not that good results. There are substantial differences physical-wise in between radial and focus shock wave. You see here an animation of how an electromagnetic focus shock wave is traveling through tissue up to 8 centimeters tissue depth. So you see the shape of the shock wave is changing by depth. As far as, let's say, energy levels are concerned, depending on your target tissue, you might end up with different energy flux densities, so energy levels, which is very, very important. So if you deal, for example, with a more insertional Achilles tendinopathy, where you might end up with some bony edema as well, you might have high energy, say higher than 0.25 millijoule. If it's only the mid portion where the issue is, you might apply medium energetic shockwave. If you try to change nerves, for example, you only need very nano energetic. So depending on your target tissue, even your energy flux densities must be different, and shockwaves are mediated by a mechanism called mechanotransduction in a protein response. It is recently shown and awarded with the Nobel Prize that there are mechanoreceptors called piezo1 and piezo2, and this was awarded in 2021 to Lebanese colleague Adem Patapoulian for the discovery of mechanoreceptors. We are aware that focus shockwave have a myriad of, or plethora of effects. So it's shown that focus shockwave can stimulate stem cells. It's shown already in 2005 that there might be, depending on the energy levels and depending on the numbers of shots, as you see, 500, 1,000, 1,500 with nano or medium energetic focus shockwave. You might have an anti-inflammatory effect as well, depending on NOS modulation. It has been recently shown that shockwave can stimulate exosomes, and exosomes are very important for the intercell communication. And the World Society for Shockwaves, the ISMST, has proposed indications depending on your shockwave experience. So beginner, advanced, expert, and experimental indications. They are listed on the ismst.com homepage. And Achilles tendinopathy is, as plantar fasciitis, patellar tendinopathy, is a beginner standard indication, because evidence-based wise, we have more than 100 papers showing that both radial and focal shockwave are quite good. A good read is Vassilos Korakakis' paper published in 2018 in the British Journal. And the most recent comprehensive paper dealing with shockwaves in athletes is published by Adam Temforty, who will speak after Amol Saxena tonight, 10 p.m. German time, as well. So a very, very good read, British Journal of Sports Medicine, just published. And I mentioned Amol. Amol was the first user in the US doing the FDA trials for shockwave, and he showed beautifully that the combination radial and focused is even better than radial or focused alone. So he will tune in later, and we will have, if you are around Boston in the beginning of March, we will celebrate the birth of the American Society for Medical Shockwave Treatment, ASMST, and Adam and Amol, as well as Karin Silbernagel, will be around. So my current best shockwave parameters, radial-wise, 0.8 to 1.5 bar, 8 hertz, so rather slow, 2000 shots with a C15 ceramic applicator. In focused electromagnetic, I'm using in between 0.07 to 0.15 millijoule, 4 to 5 hertz, 2000 shots with a standoff number 2. It's known in the studies and derived from meta-analyses that you can expect some 10 points VISA-R improvement. It is shown by Nick and Jan Dirk that eccentric plus radial pressure waves are better than eccentric training alone, published in the American Journal. And this is work in progress. Even elasticity can be substantially and fast improved by 26 kilopascal to 10 kilopascal immediate after a combined focused and radial session. And there is even an observation just shared and published, or presented by my friend Martin Ringeisen for the first time in 2022 on the DIF meeting, that in a patient who had underwent already 2 Achilles tendon ruptures with a fatty degeneration of his tendon, and he requested for pain 5 sessions of focal shockwave, the fat architecture changed after 5 months. After 3 years, you see a change in the MRI quite tremendously. So this is much different to what it looked 2.5 years before. So this is clinical cell reprogramming. So fat cells, via the mechanism, exosomes, toll-like receptor 3 activation, epigenetic plasticity, can help in clinical transdifferentiation of tissues. So fat cell into a tendon cell. It takes long, but it's obviously happening. Low-level laser therapy is helping quite a lot, even in tendons, by photobiomodulation. And I'm currently combining 808 and 904 nanometer lasers as class 3B devices. There are some randomized controlled trials suggesting that combination of low-level laser and eccentric training are quite good idea. There are laser data showing that the penetration of these 2 wavelengths is a bit different, but both are beneficial and pain-free. Oscillating magnetic fields are an evolving field, even for the Achilles tendon. We differentiate PERMF, pulse electromagnetic fields on the one hand, and electromagnetic transduction therapy machines on the other hand, depending on effective transduction power, as you can see here, and depending on speed. So EMTT is some 40 times faster than a PEMF. It is supercharging your tissue, and it's known that, for example, on the cellular level, there are different membrane potentials relevant in each and every part of your cell. And you might even, by changing the membrane potential, changing the macrophages from an M1 to an M2 response. And you might even change proliferating to non-proliferating cells depending on your membrane potential. We have shown that VEGF is stimulated by EMTT quite tremendously, and even clinical-wise, Amoy Saxena and Ludger Gerdes-Meyer have shown in a very initial report that EMTT is, when combined with a standard treatment in Achilles tendinopathy, can further help pain reducing. And it seems if you apply EMTT alone, again, that elasticity is beneficially influenced by EMTT as well. As I come to injections, Lars Öberg and Håkon Alfredsson were the first in 2002 to show an extratendinous sclerosing therapy with polydocanol. He could show a remodeling over 2 years if you apply it extra tendinously under ultrasound control. And this is what is now possible. So you see before and after SMI 10 or 11% vascularization, and immediate after an extratendinous polydocanol sclerosing, a significant reduction. You see this patient who already had shockwaves and PRP beforehand with a 11 millimeter diameter and very, very high stiffness. And the combination of polydocanol and Traumel extratendinously, as you can see here, that's why I need to know where the vessels are so I can directly hit the feeding vessel quite tremendously, and you see substantial effect even 6 days after. So this is an option. Hyaluronic acid is another option. There is a very recent report showing that both hyaluronic acid and collagen might be quite good for your tendon health in terms of changing inflammation. I apply hyaluronic acid the same fashion as polydocanol extratendinously, as you can see here, before and after with a 24 matrix probe. You can see here, even in insertional issues with a substantial inflammation, I'm coming in the Kaga fat pad. As you now see, this is my needle tip in the Kaga fat tip, in the fat pad, and then injecting slowly and gradually. You will see over 20 seconds that by beat, the vascularization is reduced. Now I'm injecting again a small portion, checking again, readjusting my needle tip, then syringe again, then readjusting, and you see a significant immediate response of the inflammation in the insertion of the Achilles tendon. You see before and after quite tremendously effects. Injection location matters. In the Achilles tendon, you are aware of the suralis nerve on the lateral side, so please inject from the medial side. If you inject from the lateral side, you might harm the sural nerve. And there is even a very interesting report that the hyaluronic acid and shockwave may play good role together, published in PLOS ONE, because shockwave is inducing CD44 receptor, and this is the main receptor for hyaluronic acid. So if you want to apply hyaluronic acid either for tendinopathies or for osteoarthritis, it is quite good to apply focus shockwave maybe a week before to have some CD44 induction. And if you have more CD44 receptors, more hyaluronic receptors, then you might end up with much more effect of your hyaluronic acid injection. So again, coming to the end, in my view, the regenerative clockwork, precision and coordination is helping your patients and your painful Achilles tendon. Thank you so much for your attention, invitation, and your friendship.